Hi, everybody. Thank you for having me. I'm from Anderson at Houston, Texas. So I just wanted to start with some lung cancer statistics, and there were 234,580 new cases. And if you look very closely, more females than males were diagnosed with lung cancer. So even though we're making really good strides in survival, because we have really good treatments, good surgical techniques, very good radiation procedures, still way too many people are being diagnosed with lung cancer. And yes, we do have very good systemic treatments as well. So what I want you to focus, and I don't have a pointer, of the 234,580 cases, and I did the math, so if anybody wants to check the math, go for it. 85% are going to have a non-small cell lung cancer, and that is just under 200,000. And at the bottom of the slide, 15% are going to have small cell lung cancer, about 35,000. Of the 200,000 or nearly 200,000 non-small cell lung cancer diagnoses, 40% or 80,000 or close to 80,000 are going to be non-squamous or adenocarcinoma, and the other 25 to 30% will be squamous cell, almost 50,000. And then you have your large cell carcinoma and non-small cell lung cancer not otherwise specified, which I don't have on the slide. So I want you to focus in on the 40% adenocarcinoma, the 79,000 number. Because on this slide, what we're saying at the top is about 50% of the 80,000 patients with adenocarcinoma are going to have some type of mutation. Which mutation, I have no idea. But of the 40,000, 25% will have a KRAS mutation, 17% will have an EGFR sensitizing mutation, and you can see all the rest of the mutations, and they're really small percentages of patients with these mutations, but we have drugs for them, we have treatments for them, so hence the improved survival. So for the next couple of slides, I'm really not going to spend a lot of time on them. I've just listed mutations and the appropriate drugs. So this is EGFR. These are the sensitizing mutations, exon 19 deletion and exon 21 L858R. Those are the 5 drugs that are FDA approved for EGFR mutations. Osimertinib as frontline treatment is $664 and change per tablet. So a 30-day supply is almost $20,000. And if your patient is insured, they're going to have a high copay. So there is a lot of work to be done. And the reason I'm bringing this up with you is that part of the cost of these drugs blends into patient adherence and compliance. So again, for the ALK, these are the approved medications, and the alectinib first line, $92 and change for 1 tablet. Alectinib, how do you give it? It's 8 tablets. It's 4 tablets BID. So 8 tablets is $741, and a 1-month supply, $22,000. So we're talking big expenditures, as what Irene alluded to earlier. ROS1, you can do crizotinib and entrectinib. The latest drug is repotrectinib. Okay, so the 1 tablet is $145, and it's a 40 milligram tablet. And so this also goes into patient education and patient compliance. For 2 weeks, the patient will take 4 tablets daily. And then after 2 weeks, they're taking 8 tablets a day. So the teaching has to be very specific. And the 4 tablets BID is about $1,100. Multiply that by 30 and you're at $34,800 per month. BRAF V600, you have the 2 doublets listed. The NTRK and the RETs, again, NTRK is the entrectinib, larotrectinib, and repotrectinib, RET, selpercatinib, and pralsetinib. MET, exon 14, capmatinib, tepotinib, and KRAS G12C, the 2 drugs are sotorasib and adagrasib. And mind you, on the sotorasib, patients take 8 tablets a day. And if time will allow, I'm going to tell you a small anecdote that I'm stealing from a colleague at University of Penn. She was taking care of an older gentleman who had a metastatic adenocarcinoma, had been previously treated. Very long story short, he had a KRAS G12C mutation. So my colleague and her oncologist started him on sotorasib, and she was doing a remote toxicity check. She called him up, how are you doing? What's going on? He goes, I'm having trouble swallowing the pills. It's like, well, you've never had a problem taking medications before. What's going on with this medicine? It was, I'm having trouble swallowing all 8 pills at once. And this poor man thought he had, because it's 8 pills, 1 time a day. So it's not 4 in the morning, it's not 4 in the evening, it's 8 pills once a day. This poor man misunderstood the instructions and was putting 8 pills in his mouth at one time. Please be explicit with your patient education. And yes, she did rectify the situation and he's fine and doing well. But I still have that story from her. And no, I'm not going to tell you who it is. Okay, so patient adherence. Adherent, it's something that sticks. So it's really the degree or extent of the patient conforming to the treatment recommendations by their oncology team. That's really what it is with respect to the timing, the dosage, and I just gave you an example of the dosage, and the frequency. And this sounds like very common sense, but if patients don't take their medications, they're not going to benefit. And it doesn't matter if it's your oncology medications, it could be a apixaban for DVT, it could be glyburide for diabetes. If the patient is not going to comply with the treatment, they're not going to benefit. So optimal adherence and persistence is when a patient follows the prescribed treatment to a T. They just do what they're told and they take the medications. Optimal adherence, they don't miss any doses, they don't take extra doses. Doses are not taken in the wrong quantity or at the wrong time. I just had a patient call up Thursday and said, I just took 2 osimertinib, and she was in panic city, and we said, okay, skip Friday's dose. Saturday, go back to 1 a day. And it was just a complete mishap. She didn't think about it. She just did it. And we said, don't worry about it. Optimal persistence is taking the medication for as long as it's prescribed and or effective, provided there are no grade 3 or grade 4 toxicities. Because then you'd really have to rethink about the treatment at a grade 3 or grade 4. Maybe changing the dosing, maybe even changing the treatment depending on what that toxicity is. So how do you measure this thing called patient adherence? Are you going to are you going to call the patient every day? No, you're not. You do remote toxicity checks, yes, but are you going to, is the patient or their spouse going to get a phone call? Did you take your medication today? I don't think so. When the patient's on the clinical trial with an oral agent, they get a pill diary. They get a pill count that they have to turn in at every clinic visit. Do you do the same thing when the medication is FDA approved and standard of care? Do you put the patient on the honor system? I tend to put my patients on the honor system, but I tell them, if there is an issue, if there is a question, do not take the medication until you speak to me. Tell me what the issue is. Tell me why you don't want to take it. Just be in contact with me. So how can we improve adherence? It's education, it's communication. It's not APPs as advanced practice providers, it's apps. Apparently there are apps that patients can download on their phone that will remind them to take the medication. On the other hand, it could be your advanced practice provider reminding the patient to take their medicine. Now, also in electronic medical records, they do have medication history with last dispense date, and you can discuss adherence when doing medication, not reconciliation, but reviewing and reconciling the medications. And this is, now I deleted the medications. This is from a patient's chart, so I really didn't want any descriptors for my patient. So the name is the name of drug. Patient SIG are the directions, the dispense, how many pills, how many refills are we giving? So we're giving 30 pills, we're giving 4 refills. When are we starting? Well, we're starting, I'm gonna go to yesterday, it was Friday, May 17th, And we're ending, let's say, September 17th. But the key column is the last dispense. When did the patient last call for a refill of the medication? And you can track it. Are they calling too early? Are they calling too late? You can track the dispense dates. And that helps to not accuse the patient that they're taking the patient wrong, but find out, okay, what's going on? We dispensed this September 1st and you're going to stop at September 18th. What happened here? What went wrong? Education. Education is probably what I spend the bulk of my day doing. So it's patient and family education, explaining the disease, the stage, explaining mutation testing, including PD-L1, and what the results mean. I have patients so hyped up on, do I have a mutation? Do I have a mutation? I'm like, oh, if you don't worry. We have other very good treatment, just not oral treatment. The treatment recommendations, I do explain the cost of drugs. And in explaining the cost of drugs, I was like, this drug is not going to be at your neighborhood pharmacy. This drug is coming from a specialty pharmacy. It costs too much to have at a local pharmacy. The prior authorization process and the possible delay in starting the oral treatment, because sometimes you have to do the prior authorization so that the patient can get the drug. Now, I will say that a lot of the specialty pharmacies we work with, once we have prior authorization, that drug is sent out overnight and the patient starts it within 24 hours of prior authorization. So communication, patient accessing the team either through inbox messaging in their electronic medical record, calling the office, calling the triage line, even sending us emails. They can send us emails. And it's up to the practitioner and the providers to respond to the patient messages and concerns as quickly as possible. I have an upcoming clinic of 23 patients next Wednesday, and I can tell you I'm not going to be able to respond to a patient message, but what I can tell the patient is, I have your message, I've read it, I will respond Thursday. I'm just over my head in seeing patients right now. As long as they know you have the message and you will respond to them, they'll sit back and say, okay, I can wait to see. And communication with other providers or other services, maybe cardiologists, maybe endocrinologists. A lot of the drugs that I just showed do have cardiac toxicities. One of my patients who had an ALK mutation, his ALK mutation was found because he was having cardiac ablation for, what did I just blank on? Atrial fibrillation with ventricular response. So he had cardiac ablation, and then during a cardiac ablation, they did a chest x-ray, and lo and behold, he had lung cancer. Well, he was on metoprolol, and we put him on an ALK inhibitor, and the ALK inhibitor prolongs QT wave prolongation. So he came to clinic, symptomatic bradycardia. And so we called his cardiologist, and he was like, guess what? And his cardiologist was it all, gave us the instructions to taper him off the metoprolol. Didn't need the metoprolol, stayed on the ALK inhibitor. Heart rate responded, not immediately, but improved over time. So there needs to be communication and coordination with other providers. The cost of the drug, as I showed you on some of the other slides, is prohibitive. Even with insurance, the copay can be high. I have two patients who both have EGFR mutations. Even with insurance, one woman's copay was $2,700, and my other patient's copay was $3,300. The first woman whose copay was $2,700, her daughter happens to work in the institution, and we know each other, and she and her husband, paid the copay. My second patient, she's like, I just can't afford $3,300. So what do? I am extremely, extremely fortunate. And I'm almost sure Rush has this at your institution, at this institution. We have a specialty pharmacy that does nothing but these medications, not just for lung cancer, but for all of our malignancies. And within the specialty pharmacy, they have pharmacy specialists who work with patients, getting them on patient assistance programs. And that's what we did here. Even though she had insurance, she said, I don't have $3,300. I mean, it's a lot of money. Reasons for non-compliance, toxicities, ILD, GI complaints, dermatologic issues. Well, if your patient is coughing and short of breath, maybe they're going to say, I don't want to take my medication. If they're having GI toxicities, and since we are after lunch, I'm going to skip the graphics. They don't want to be in one room all day long, and they're doing their thing. Dermatologic issues is an interesting thing. I once had a patient who was a salesman, and it's not that looks were so important to him as much as he interacted face-to-face with people. This is way before COVID-19 hit. And so he was on an EGFR inhibitor, and he had a gosh awful rash, and he said, I can't take this. I can't take this. I look like a teenager with this rash. I can't get any sales. So you really have to take into consideration not just what the patient does, but how this will affect him. And yes, we have become much better at dealing with the GI toxicities. I just want to go back to cost of drug for a second, as expensive as it is. Well, sometimes, patient has a drug, they've met their copay, but they're running out, they're getting towards the end of their supply. Well, maybe they start taking half the drug to make that prescription last longer. So it's not just not taking the drug, it's maybe not taking the drug not as prescribed. And that is being non-adherent and non-compliant. So you really have to look at things. And complications, if you have a patient in the hospital, they should not be taking their inhibiting agent. That's a reason, and the patient should tell you if they're in the hospital, or their spouse should let you know. But if they come to clinic and they have 20 pills and you say, why do you have 20 pills remaining when we refilled this a month? Oh, it's in the hospital. Okay, for what? Oh, I had surgery. But you have given us a heads up about this. So really, it's important. It's important. Reasons to hold treatment need to come from the team. So again, if it goes back to toxicities, if they're unbearable, we might tell the patient, you know what, stay off the drug, maybe through the weekend. Call me Monday or Tuesday, how are you feeling? Whether it's GI toxicities, whether it's coughing or shortness of breath, just, stay off the drug for a couple of days, see how you feel. The complications, the intercurrent infections, the hospitalizations, we've got to sort through this. We're not sure what's causing what. So hold off on the inhibiting agent. Let's figure this out. Now, again, if the patient needs to hold treatment, the treatment needs to come from the recommendation needs to come from the oncology team. So in summary, explaining to the patient and family the rationale for mutation testing, including PD-L1 and the significance of the results. And I really do like to tell patients, it's just going to guide us in the treatment decision. And I leave out prognosis and everything else. I was like, it's just going to guide us in the treatment decision. I do educate the patients on the cost of the drugs. And no, I don't tell them it's $22,000. I just say it's a very expensive drug. I'm going to have to do a prior authorization for it. So even though we want you to start treatment May 17th, it might not be until May 20th or the 21st before you start treatment. That is okay. I reassure them it is okay. The importance of taking the oral agent as prescribed is once a day, just same time every day, once a day. And reporting of the toxicities. I said, you've got to let us know what's going on. What are you having? Communication with the oncology team is the patient or family communicating with us. And patient adherence and compliance applies to all medications. Think of apixaban. They have a starter pack, and then they go to the BID dosing. And the starter pack is what? 20 milligrams BID for a week, and then they go to 10 milligrams, 5 milligrams BID for onward. So it's not just oncolytics, it's all medications. It's anticoagulants, it's antihypertensives, it's oral hypoglycemic agents for your diabetic patients. it applies to everything. And so I really did this talk much faster than I thought I would. So I do have some times for questions. I'm waiting.
No, I think one of the biggest things, because I work outpatient infusion therapy, and I think one of the biggest challenges is the patients trying to keep up with all the meds, who's on first and things like that. I do find that would help them if they were like, even though we give them the after visit paperwork and it has all the meds that they say that they take, they really don't know if they took it or not. Is that the pink pill? Is that the purple one? I don't know. I usually take it at this time, things like that. So we're trying to come up with a sheet where we can put all their meds on there and they can mark the box and say, yes, I took it today.
I think that's a good idea. I think that's a good idea. And sometimes I'll tell a patient, you know what? You stay on all your other medicines that you're already on, whatever they are. Excuse me. I say, take your oncology medicine, whichever one it is, put it aside. And I say, take it at night. So this is your nighttime dose. And like, if you want to put PM on the bottle, put PM on the bottle. And if the patient wants to count how many pills, if they're starting day 1, they're going to have 29 pills left, and day 2, 28, and so on. They can do that. Or if they really want to, they can buy one of those medication trays and just put the oral oncolytic in it and just take that. But I think you have a good idea. Any other questions?
People that are online. We have a great group joining us online. And then for I talk, someone just said, they just want to let the group know that she has a patient that is diagnosed in 2015, stage 4 EGFR, and it came he's been on a TKI the entire time. They wanted to basically agree with what you said about how helpful, especially pharmacists, pharmacy
Yes.
helping with costs, things like that. If anyone is online and you have questions, go ahead and type them in.